While Milwaukee County's efforts to transform its adult mental health care system have received considerable attention in recent years, far less attention has been devoted to the financial elements of mental health redesign. For example, how much is being saved from the county's efforts to vastly reduce bed capacity at the Milwaukee County Mental Health Complex? And, perhaps more important, can continued bed reductions generate the property tax levy savings that will be required to achieve desired levels of community-based care? In a report released in March 2015, the Public Policy Forum attempts to answer those questions. The report begins by examining financial trends from the 2010 to 2013 timeframe, which was the period in which the county's Behavioral Health Division initiated various redesign strategies aimed at moving toward a community-based system of care. Between 2010 and 2013, adult inpatient capacity at the mental health complex decreased by 31%. In addition, patient days were sharply reduced at long-term care facilities as the county prepared to close its Hilltop and Rehab Central operations. On the community side, meanwhile, a wide array of new treatment, recovery, and crisis services were added. Direct hospital-related expenditures at the mental health complex decreased by $5.5 million, an amount that intuitively would appear to correlate with the decline in bed capacity. However, we found that indirect costs unexpectedly increased by $2.5 million. To some degree, this was caused by factors beyond BHD's control, such as the Central Budget Office's determination of BHD's legacy costs from retired employees, facility expenses, and charges from other departments. We also found that overall staffing levels at the mental health complex remained largely the same despite the reduced patient volume. This was largely attributed to increased staffing levels at the Psychiatric Emergency Room, also known as PCS, which may have reflected a need to utilize clinical staff freed up from inpatient and long-term care downsizing to address previous understaffing. Overall, our trend analysis found that a key objective of mental health redesign, to use inpatient and long-term care downsizing as a means of freeing up property tax resources to invest in community-based services, had not been achieved as of the end of 2013. In fact, BHD needed $360,000 more in property tax levy support for the mental health complex in 2013 than it did 3 years earlier. We then turned to the 2014 and 2015 budgets to determine whether any of the trends observed for the previous 4 years had reversed and whether additional savings were materializing from continued mental health complex downsizing in those years. We found that the financial benefits associated with sharper declines in bed capacity had indeed become more pronounced. For example, property tax levy expenditures for mental health complex service areas were budgeted to fall by about $7 million in 2015 when compared with 2013 actual amounts. However, the potential for greater savings still was limited by BHD's inability to substantially reduce indirect costs, which were projected to decline by only 4%, and by substantial budgeted reductions in patient revenue in conjunction with a reduced census. We also observed that increased staffing and expenditure levels at PCS continued to partially offset inpatient and long-term care savings. Finally, we used the information and insights gained from our trend analysis to conduct financial modeling for 60, 32, and 16-bed adult inpatient scenarios. Our modeling showed that BHD would need about $3 million of additional property tax levy in 2017 to support its adult inpatient beds and PCS than it budgeted in 2015. However, because $4.2 million in net savings would be derived from the closure of Rehab Central at the end of 2015, there would be a total of about $1.2 million available for community reinvestment under that scenario in 2017. We also found that BHD could generate a $5 million property tax levy savings in 2017 by downsizing from 60 to 32 adult inpatient beds, and an $8.8 million savings by downsizing to 16 adult inpatient beds. Again, both of those savings amounts include the positive fiscal impact associated with the closure of Rehab Central. A key question is whether an investment of the projected savings from the 32 and 16 bed scenarios in community-based services would be sufficient to appropriately offset the increased need for such services in light of reduced inpatient bed capacity. Our modeling exercise also highlighted the fundamental constraints that will continue to impact BHD's financial future. The first is that the mental health complex's indirect costs are only loosely linked to its bed capacity, and this factor will continue to curtail overall savings that can be achieved with future downsizing initiatives. Second, because key components of BHD's indirect cost structure are linked to its existing facility and its treatment as a regular department of Milwaukee County government, there is little it can do to reduce indirect costs without changes to those two circumstances. Finally, while BHD can continue to generate sizable direct cost savings from additional reductions in inpatient bed capacity, the direct cost pressures associated with continued operation of PCS at its existing capacity will erode those savings and reduce the amounts available for community reinvestment. For more information about the fiscal impacts of mental health redesign in Milwaukee County, read the full report at publicpolicyforum.org.